Question 1. Dr. Taylor is a family physician who is assessing a 58-year-old male patient, Mr. Harris, who presents with complaints of persistent fatigue, weight loss, and abdominal pain. Mr. Harris has a history of hypertension, is a smoker, and reports a family history of gastrointestinal cancer. After a thorough clinical evaluation, Dr. Taylor considers the possibility of a malignancy and orders an abdominal ultrasound. Which of the following is the most appropriate next step in managing Mr. Harris's condition? A. Prescribe antacids and monitor for improvement. B. Recommend immediate surgery to remove the suspected tumor. C. Refer Mr. Harris to a gastroenterologist for further diagnostic evaluation. D. Order a complete blood count, CBC, and liver function tests. Answer C. Refer Mr. Harris to a gastroenterologist for further diagnostic evaluation. Explanation. In this case, Mr. Harris is presenting with red flag symptoms that warrant further investigation, particularly given his risk factors, age, smoking, family history. Although an abdominal ultrasound is a good starting point, it is important for Dr. Taylor to refer Mr. Harris to a gastroenterologist for specialized diagnostic evaluation, including potentially a colonoscopy or endoscopy to confirm the diagnosis. Immediate surgery without a clear diagnosis or further testing would not be appropriate. Monitoring with antacids is not appropriate given the possibility of a malignancy, and ordering liver function tests may not provide sufficient information about the specific gastrointestinal issue. Question 2. Which of the following best describes the concept of autonomy in medical ethics? A. The obligation of healthcare providers to do no harm to the patient. B. The patient's right to make decisions about their own healthcare even if it conflicts with medical advice. C. The requirement for physicians to treat patients in accordance with established medical guidelines. D. The duty of healthcare providers to act in the best interest of the patient, regardless of the patient's preferences. Answer B. The patient's right to make decisions about their own healthcare even if it conflicts with medical advice. Explanation. Autonomy is a fundamental principle of medical ethics that emphasizes the patient's right to make informed decisions about their healthcare. This includes the right to refuse or choose treatment even if the decision goes against medical advice. It is essential that healthcare professionals respect and support this right by providing all information, ensuring understanding and honoring the patient's choices. The other options refer to different ethical principles: non-maleficence, doing no harm; beneficence, acting in the best interest of the patient; and justice, ensuring fairness and equality in treatment, but they do not define autonomy. Question 3, scenario-based. Mrs. Andrews is a 45-year-old woman who comes to the emergency department with severe chest pain, shortness of breath, and dizziness. Her medical history includes hypertension, obesity, and a previous myocardial infarction 5 years ago. Her family history includes early onset coronary artery disease (CAT). On physical examination, her blood pressure is elevated and her heart rate is irregular. The ECG shows St. segment elevation. What is the most appropriate immediate management step for Mrs. Andrews? A. Prescribe a beta blocker and send her home with instructions for outpatient follow-up. B. Perform thrombolysis or percutaneous coronary intervention (ECI) to restore coronary blood flow. C. Order a chest X-ray and monitor her in the hospital for 24 hours. D. Begin intravenous Romanuids and observe her condition for worsening. Answer B. Perform thrombolysis or percutaneous coronary intervention (ECI) to restore coronary blood flow. Explanation. Mrs. Andrews is exhibiting signs of an acute myocardial infarction as indicated by her chest pain, shortness of breath, elevated blood pressure, irregular heart rate, and St. segment elevation on the ECG. Immediate intervention is necessary to restore blood flow to the affected heart tissue. The two prime interventions are thrombolysis, administering clot-dissolving drugs, or percutaneous coronary intervention (ECI) to mechanically open blocked coronary arteries. Delaying or underestimating the severity of the MI could lead to significant myocardial damage. The other options do not adequately address the acute nature of her condition. Beta blockers and outpatient follow-up are inappropriate for an ongoing MI. Chest X-ray is not helpful in the acute setting. Romanuids alone will not treat the underlying coronary blockage. Question 4. A 54-year-old male presents to the emergency department with a sudden onset of chest pain, shortness of breath, and diaphoresis. He has a history of hypertension, hyperlipidemia, and smoking. The pain is retrosternal and radiates to the left arm. On examination, his blood pressure is 169 mmHg, heart rate is 110 bpm, and he has cold, clammy skin. It shows segment elevation in the anterior leads. What is the most likely diagnosis and what is the immediate management? A. Acute pericarditis, inosedzin colchicine. B. Acute myocardial infarction, STEMI, aspirin, nitroglycerin, and early reperfusion therapy. C. Pulmonary embolism, anticoagulation and fibrinolysis. D. Aortic dissection. Blood pressure control and surgery. Answer: B. Acute myocardial infarction, STEMI, aspirin, nitroglycerin, and early reperfusion therapy. Explanation: the patient presents with symptoms characteristic of an acute myocardial infarction, STEMI, including chest pain, diaphoresis, and radiating pain, along with classic ECG findings of segment elevation. Immediate management includes aspirin for platelet inhibition, nitroglycerin for pain relief and to reduce myocardial oxygen demand, and early reperfusion therapy. E.g. percutaneous coronary intervention or thrombolytics to restore coronary blood flow. This diagnosis and treatment plan are aligned with current STEMI management guidelines. Why not? A. Acute pericarditis typically presents with pleuritic chest pain, pericardial friction rub, and diffuse elevation across the ECG, unlike the localized segment elevation seen here. Why not? C. Pulmonary embolism would cause sudden onset shortness of breath and pleuritic chest pain, but would not explain the segment elevation seen on the ECG. Why not? D. Aortic dissection presents with severe, sharp chest pain that radiates to the back and a difference in blood pressure between arms, which is not seen here. Question 5. A 24-year-old female presents with severe headaches, nausea, and visual disturbances. On examination, her blood pressure is 160/100 mmHg and fundoscopy shows papilledema. She is recently pregnant at 20 weeks gestation. Her urine dipstick is positive for 3-proteinuria. What is the most likely diagnosis and how should this be managed in pregnancy? A. Eclampsia, magnesium sulfate, and antihypertensive therapy. B. Preeclampsia, antihypertensive therapy and monitoring. C. Gestational hypertension, observation and blood pressure monitoring. D. Chronic hypertension, antihypertensive therapy and bed rest. Answer: B. Preeclampsia, antihypertensive therapy and monitoring. Explanation: the patient's symptoms of headache, nausea, visual disturbances, high blood pressure, proteinuria, and papilledema are consistent with preeclampsia, pregnancy-related hypertensive disorder typically occurring after 20 weeks gestation. Immediate management includes antihypertensive therapy, G. labetalol or nifedipine, and close monitoring to prevent complications, clamtic seizures, stroke, or organ damage. If the condition progresses, delivery may be required to prevent further maternal and fetal complications. Why not? A. Eclampsia includes all features of preeclampsia, with the addition of seizures, which this patient does not have. Why not? C. Gestational hypertension involves high blood pressure without significant proteinuria or end organ damage, unlike the patient's findings. Why not? D. Chronic hypertension typically occurs before pregnancy and is not associated with significant proteinuria, as seen here. Question 6. Mr. Thompson, a 67-year-old man, presents with a 2-day history of fever, chills, and productive cough with green sputum. He also complains of pleuritic chest pain and shortness of breath. On examination, he is febrile, 39-dec tachypneic, and has dullness to percussion on the right side of the chest. Chest X-ray reveals consolidation in the right lower lobe with pleural effusion. What is the most likely diagnosis and the first-line treatment? A. Community-acquired pneumonia with parapneumonic effusion. Oral antibiotics. B. Tuberculosis, initiation of anti-tuberculosis therapy. C. Acute bronchitis, supportive care and hydration. D. Bacterial pneumonia with parapneumonic effusion, intravenous antibiotics and drainage. Answer: D. Bacterial pneumonia with parapneumonic effusion, intravenous antibiotics and drainage. Explanation: Mr. Thompson's presentation of fever, productive cough with green sputum, pleuritic chest pain, and findings of consolidation with pleural effusion on chest X-ray are consistent with bacterial pneumonia complicated by parapneumonic effusion. The management includes intravenous antibiotics tailored to likely pathogens, e.g. Streptococcus pneumoniae, Staphylococcus aureus, drainage of the pleural effusion if necessary via phorasynthesis or chest tube. Why not? A. Oral antibiotics may not be sufficient in severe cases of pneumonia, with pleural effusion and antibiotics are preferred for more serious cases. Why not? B. Tuberculosis is less likely in the absence of risk factors, night sweats, and prolonged symptoms. Why not C? Acute bronchitis is typically viral and would not explain the consolidate or pleural effusions seen here. Question 7, scenario-based. Mrs. Clark, a 42-year-old woman, comes to your office with complaints of joint pain and swelling, particularly in her wrists, knees, and small joints of her hands. She has had morning stiffness lasting over an hour for the past 6 months. Her symptoms are worse after long periods of inactivity and improve with movement. On examination, she has bilateral wrist and knee swelling, and the joints are warm to touch. Rheumatoid factor and anti-EP antibodies are positive. Was the most likely diagnosis and the first-line treatment A. Osteoarthritis in NSAIDs and physical therapy, B. Rheumatoid arthritis, methotrexate and corticosteroids, C. Systemic lupus erythematosus, hydroxychloroquine and corticosteroids, D. Psoriatic arthritis, AF inhibitors and methotrexate. Answer: B. Rheumatoid arthritis and methotrexate and corticosteroids. Explanation: Mrs. Clark, symptoms of symmetric joint pain, morning stiffness, and swelling in the wrists, knees, and hands, along with positive rheumatoid factor and anti-EP antibodies, are characteristic of rheumatoid arthritis, RA. The first-line treatment for RA includes disease-modifying antihematic drugs, DMARDs, with methotrexate being the most commonly used, with corticosteroids for symptom relief. Why not A? Osteoarthritis typically causes asymmetric joint pain and is less likely to present with prolonged morning stiffness or systemic symptoms like RA. Why not C? Systemic lupus erythematosus can present with joint involvement, but the pattern of joint symptoms and lab results positive at CP are more suggestive of RA. Why not D? Psoriatic arthritis presents with different pattern joint involvement, e.g. dactylitis or enthesitis, and skin symptoms, psoriases, which are not described in this case. Question 8. 33-year-old male with a history of intravenous drug use presents with fever, malaise, and a new heart murmur. Blood cultures grow Streptococcus viridans. An echocardiogram reveals a vegetation on the mitral valve. Was the most likely diagnosis and the first-line treatment approach A. Acute bacterial endocarditis, antibiotics, penicillin and gentamicin. B. Subacute bacterial endocarditis. Oral antibiotics, amoxicillin. C. Rheumatic fever, aspirin and corticosteroids. D. Myocardial infarction, antiplatelet therapy and anticoagulation. Answer A. Acute bacterial endocarditis. Antibiotics, penicillin and gentamicin. Explanation: this patient's symptoms of fever, malaise, and heart murmur, along with blood culture growth of Streptococcus viridans and echocardiographic findings of vegetation on the mitral valve, are typical of infective endocarditis. The most likely causative organism in patient with intravenous drug use is Streptococcus viridans, and the first-line treatment is intravenous antibiotics, combination of penicillin and gentamicin. Why not B? Subacute bacterial endocarditis is less acute presentation, typically with more indolent course, and is often associated with different microbial profile. Why not C? Rheumatic fever is associated with recent throat infection with Streptococcus pyogenes, not intravenous drug use or endocarditis with Streptococcus viridans. Why not D? Myocardial infarction is typically present with fever, new murmur, or positive blood cultures. Question 9. A 28-year-old woman presents with complaints of weight gain, cold intolerance, constipation, and dry skin. Her family history is significant for autoimmune thyroid disease. On examination, she has goiter and bradycardia. Her thyroid function tests show an elevated TH and low. What is the most likely diagnosis and what is the first-line treatment? A. Hypothyroidism due to Hashimoto's thyroiditis, levothyroxine. B. Hypothyroidism due to Graves' disease, methimazole. C. Subclinical hypothyroidism and no treatment necessary. D. Pituitary adenoma, surgery and or radiotherapy. Answer A. Hypothyroidism due to Hashimoto's thyroiditis, levothyroxine. Explanation: the patient's symptoms of weight gain, cold intolerance, constipation, dry skin, bradycardia, and goiter, along with laboratory findings of elevated TH and LUT, are consistent with hypothyroidism due to Hashimoto's thyroiditis, an autoimmune disorder. First-line treatment is levothyroxine, which is a synthetic form of T that normalizes thyroid hormone levels. Why not B? Hypothyroidism would present with symptoms such as weight loss, heat intolerance, and tachycardia, which are absent in this patient. Why not C? Subclinical hyperthyroidism has mild elevation in Th with normal levels, which is not seen in this patient. Why not D? Pituitary adenoma would typically present with other endocrine abnormalities, such as elevated prolactin or hormone, and would not cause low thyroid hormone levels in isolation. Question 10. A 60-year-old woman presents with fatigue, increased thirst, and polyuria. She has a history of hypertension, obesity, and a family history of diabetes. Laboratory tests show a fasting blood glucose level of 130 mdl and HbAC of 7.5%. What is the most likely diagnosis and what is the initial management strategy? A. Type 1 diabetes. Insulin therapy. B. Type 2 diabetes. Lifestyle modifications and metformin. C. Prediabetes, lifestyle modifications only. D. Diabetic ketoacidosis, the intravenous fluids and insulin. Answer. B. Type 2 diabetes, lifestyle modifications and metformin. Explanation. The patient's symptoms of fatigue, increased thirst, and polyuria, along with a fasting blood glucose level of 130 mdl and an HbAC of 7.5%, are consistent with the diagnosis of type 2 diabetes. Initial management typically includes lifestyle modifications, diet and exercise, and metformin to help improve sensitivity and control blood glucose. Why not A? Type 1 diabetes typically presents earlier in life and is characterized by insulin dependence, often with more acute symptoms such as weight loss and diabetic ketoacidosis. Why not C? The patient's HbAC is above the threshold for prediabetes, which is 6.5%, indicating established diabetes rather than prediabetes. Why not D? Diabetic ketoacidosis is acute complication of diabetes and would present with more severe symptoms such as vomiting, abdominal pain, and acidosis, which are not present here. Question 11. A 65-year-old male presents with confusion, slurred speech, and right-sided weakness. He has a history of hypertension and type 2 diabetes. On examination, his blood pressure is 100 to 100 Thg and he has a positive Babinski sign on the right side. A K of the head shows an ischemic infarction in the left middle cerebral artery territory. What is the most likely diagnosis and what is the initial management? A. Acute ischemic stroke, intravenous alteplase. B. Transient ischemic attack, aspirin. C. Acute hemorrhagic stroke of blood pressure control. D. Bell's palsy, corticosteroids. Answer A. Acute ischemic stroke, intravenous alteplase. Explanation. The patient's acute onset of neurological symptoms, including confusion, slurred speech, and weakness on the right side, suggests an ischemic stroke. CT scan confirming an ischemic infarction in the left middle cerebral artery territory further supports this. The most appropriate initial management for acute ischemic stroke is the administration of intravenous thrombolytic agent if the patient is eligible and the time window, typically within 4.5 hours of symptom onset, is appropriate. Why not B? Transient ischemic attack TIA typically presents with symptoms that resolve within 24 hours and does not show an infarction on CT. Why not C? Acute hemorrhagic stroke would present with sudden severe headache, vomiting, and possible decrease in consciousness. Blood pressure control. Essential in hemorrhagic strokes, but this patient has an ischemic stroke. Why not D? Bell's palsy involves facial paralysis without other neurological signs, and there is no indication of this condition here. Question 12. A 33-year-old female presents with a rash and joint pain. She reports a history of photosensitivity, oral ulcers, and persistent fatigue. Laboratory findings show a positive anti-nuclear antibody on a test, the positive anti-double-strand eDNA antibody, and low complement levels. CERN-C. What is the most likely diagnosis and what is the initial treatment? A. Systemic lupus erythematosus, hydroxychloroquine. B. Rheumatoid arthritis, methotrexate. C. Psoriasis, topical corticosteroids. D. Scleroderma immunosuppressants. Answer A. Systemic lupus erythematosus, hydroxychloroquine. Explanation. The patient's symptoms of photosensitivity, oral ulcers, joint pain, and fatigue combined with laboratory findings of a positive DNA antibody and low complement levels are consistent with systemic lupus erythematosus. SLE hydroxychloroquine is the first-line treatment for SLE as it helps manage disease activity and reduce, particularly in the skin and joints. Why not B? Rheumatoid arthritis typically presents with symmetrical joint pain, particularly in the small joints, and does not commonly present with photosensitivity, oral ulcers, or positive DNA antibodies. Why not C? Psoriasis is characterized by well-demarcated, scaly plaques usually on extensor surfaces and does not cause the systemic symptoms or positive antibody tests seen in patient. Why not D? Scleroderma involves skin thickening and tightness, Raynaud's phenomenon, and visceral organ involvement, which is not consistent with this patient's presentation. Question 13. A 50-year-old male with a history of alcohol use disorder presents with nausea, vomiting, confusion, and lethargy. On examination, his liver is palpable and there is mild jaundice. His laboratory results show an elevated aspartate aminotransferase and alt-alanine aminotransferase level, as well as an elevated gamma-glutamyl transferase GT level. What is the most likely diagnosis and what is the initial management? A. Acute alcoholic hepatitis, supportive care and abstinence from alcohol. B. Chronic viral hepatitis, antiviral therapy. C. Cirrhosis liver transplant. D. Gallbladder disease, a cholecystectomy. Answer A. Acute alcoholic hepatitis, supportive care and abstinence from alcohol. Explanation: the patient's history of alcohol use disorder, elevated liver enzymes AST/AGDT, and signs of liver dysfunction, nausea, vomiting, confusion, jaundice suggest acute alcoholic hepatitis. Supportive care, including hydration and nutritional support, along with complete abstinence from alcohol, is the cornerstone of treatment. Cases may require corticosteroids or liver transplantation in extreme cases. Why not B? Chronic viral hepatitis would typically present with more chronic symptoms and a different pattern of liver enzyme elevations, including higher alt than AST, and would be diagnosed by viral serology. Why not C? Cirrhosis may present with similar symptoms but would have a much more insidious onset. Additionally, a history of alcohol use disorder. Critical for diagnosis. Why not D? Gallbladder disease typically presents with right upper quadrant pain, fever, and positive Murphy's sign, which is not observed in this patient. Question 14. A 28-year-old male presents with a painful swollen knee joint following an injury during a soccer game. The knee is swollen and tender and the patient is unable to fully extend it. A physical examination reveals a positive Latchman test and a positive anterior draw test. What is the most likely diagnosis and what is the next step in management? A. Anterior cruciate ligament tear, MRI of the knee. B. Meniscal tear and knee arthroscopy. C. Patellar dislocation, reduction and immobilization. D. Quadriceps tendon rupture, a surgical repair. Answer A. Anterior cruciate ligament tear. MRI of the knee. Explanation: the positive Latchman test and anterior draw test are indicative of an anterior cruciate ligament ankle tear, which is commonly associated with sports injuries. The next step in management is an MRI of the knee to confirm the diagnosis and assess the extent of damage, which will guide treatment, including possible surgical intervention. Why not B? Meniscal tears often present with mechanical symptoms such as or clicking, but the clinical signs, Latchman and anterior draw tests, are more indicative of an ankle injury. Why not C? Patellar dislocation typically presents with the knee visibly out of place, and the physical examination would reveal an abnormal patellar position, which is not described in this case. Why not D? Quadriceps tendon rupture presents with a palpable defect in the tendon and an inability to extend the knee, which is not consistent with patient's findings. Question 15. A 40-year-old woman presents with a history of progressive abdominal pain, bloating, and constipation. She also reports unintentional weight loss and recent episodes of bright red rectal bleeding. On examination, she has a palpable mass in the lower abdomen. A colonoscopy reveals a large obstructing tumor in the sigmoid colon. What is the most likely diagnosis and what is the next step in management? A. Colon cancer, surgical resection and staging. B. Irritable bowel syndrome, dietary changes and fiber supplementation. C. Inflammatory bowel disease, corticosteroids and immunosuppressants. D. Diverticulitis, antibiotic therapy and surgical intervention. Answer A. Colon cancer, surgical resection and staging. Explanation: the patient's symptoms of progressive abdominal pain, bloating, constipation, unintentional weight loss, and rectal bleeding, along with the findings of mass on examination and an obstructing tumor on colonoscopy, are highly suggestive of colon cancer. The next step in management is surgical resection of the tumor, followed by staging, CT scan, or MRI to determine the extent of the disease and guide further treatment, such as chemotherapy if necessary. Why not B? Irritable bowel syndrome. It does not typically present with weight loss, rectal bleeding, or palpable mass. It is functional disorder without organic pathology. Why not C, inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, typically presents with diarrhea, not constipation, and would not cause mass on examination. Why not D, diverticulitis, typically presents with localized abdominal pain, usually in the left lower quadrant, fever and changes in bowel habits, but it does not present with rectal bleeding or on physical examination. Question 16. A 45-year-old woman presents with difficulty swallowing, weight loss, and regurgitation of food. She reports a history of intermittent chest pain and heartburn, which have worsened over the past few months. On examination, she has halitosis and a slightly distended abdomen. An esophagram reveals a large dilated esophagus with food retention. What is the most likely diagnosis and what is the next step in management? A. Chelea, esophageal manometry and treatment with pneumatic dilation or surgery. B. Gastroesophageal reflux disease, GERD, proton pump inhibitors, PPIs. C. Esophageal cancer, endoscopy and biopsy. D. Esophagitis, corticosteroids and acid suppression. Answer A. Achalasia, esophageal manometry and treatment with pneumatic dilation or surgery. Explanation. The patient's symptoms of dysphagia, regurgitation of food, weight loss, and halitosis, along with the findings of dilated esophagus with food retention on an esophagram, suggest achalasia. The next step in management is esophageal manometry to confirm the diagnosis. Treatment options for achalasia include pneumatic dilation, which is first-line non-surgical approach, or surgery. Helomotomy. Why not B? GERD typically presents with heartburn and regurgitation but does not cause dilated esophagus or food retention. The patient's weight loss and dysphagia are not typical of GERD. Why not C? Esophageal cancer may present with dysphagia, but it would typically not cause food retention or dilated esophagus without other signs of malignancy such as weight loss and lymphadenopathy. Why not D? Esophagitis presents with pain on swallowing and acid reflux, but it does not cause the large esophageal dilation seen in this patient. Question 17. A 68-year-old male with a history of smoking presents with a persistent cough, hemoptysis, and weight loss. He has a history of chronic bronchitis. On examination, he is cachectic and has decreased breath sounds on the left side. A chest X-ray reveals a large mass in the left upper lobe with mediastinal lymphadenopathy. What is the most likely diagnosis and what is the next step in management? A. Non-small cell lung cancer. Akin for staging and biopsy. B. Chronic obstructive pulmonary disease, COP to exacerbation, bronchodilators and steroids. C. Tuberculosis, sputum culture for Mycobacterium tuberculosis. D. Pneumonia, antibiotics and supportive care. Answer A. Non-small cell lung cancer. Akin for staging and biopsy. Explanation. The patient's smoking history, persistent cough, hemoptysis, weight loss, and the finding of a mass in the left upper lobe with mediastinal lymphadenopathy on chest X-ray are highly suggestive of lung cancer, specifically non-small cell lung cancer, SLC. The next step in management is akin for further staging, followed by a biopsy to confirm the diagnosis and guide treatment options, e.g. surgery, chemotherapy, or radiation. Why not B? Chronic obstructive pulmonary disease, COP to exacerbation, typically presents with wheezing, increased sputum production, and shortness of breath, but does not explain the mass or weight loss seen here. Why not C? Tuberculosis may present with a chronic cough and hemoptysis, but the mass and mediastinal lymphadenopathy are more suggestive of cancer rather than an infectious process. Why not D? Pneumonia would present with more acute symptoms such as fever, pleuritic chest pain, and cough, along with localized crackles or consolidation on examination, which are not seen in this patient. Question 18. A 25-year-old female presents with a history of excessive thirst, polyuria, and dry skin. She also reports weight loss despite her good appetite. Her laboratory results show a random blood glucose level of 450 mdl and an ATIC of 11.5%. What is the most likely diagnosis and what is the initial treatment? A. Type 1 diabetes mellitus. Insulin therapy. B. Type 2 diabetes mellitus. Metformin. C. Hypothyroidism and antithyroid medication. D. Diabetic ketoacidosis, intravenous fluids, and insulin. Answer A. Type 1 diabetes mellitus, insulin therapy. Explanation. The patient's symptoms of excessive thirst, polyuria, dry skin, weight loss despite good appetite, and significantly elevated blood glucose levels are suggestive of diabetes mellitus. The elevated HbAC of 11.5% indicates poor long-term glucose control. Type 1 diabetes mellitus is characterized by autoimmune destruction of pancreatic betas, leading to absolute insulin deficiency. The initial treatment is insulin therapy to control blood glucose levels. Why not B? Type 2 diabetes mellitus is more common in adults and is usually managed with oral medications like metformin. This patient's age, acute presentation, and severity of symptoms suggest type 1 diabetes. Why not C? Hyperthyroidism can cause weight loss and polyuria, but is not associated with blood glucose or elevated HbAC levels. Why not D? Diabetic ketoacidosis (DKA) can cause similar symptoms, but it is usually seen in patients with known type 1 diabetes and is characterized by metabolic acidosis and ketonuria. The patient here has not yet developed ketoacidosis, and the primary issue is hypoglycemia without evidence of ketosis. Question 19. A 70-year-old male with a history of coronary artery disease and hypertension presents with sudden onset severe chest pain radiating to his back. His blood pressure is 109 to 100 mmHg and he is diaphoretic. A angiogram reveals a tear in the aortic intima. What is the most likely diagnosis and what is the next step in management? A. Aortic dissection, blood pressure control and surgery. B. Acute myocardial infarction, aspirin and thrombolytics. C. Pulmonary embolism, anticoagulation therapy. D. Pericarditis, non-steroidal anti-inflammatory drugs, NSAIDs. Answer A. Aortic dissection of blood pressure control and surgery. Explanation. The patient's sudden onset severe chest pain radiating to the back along with the history of hypertension strongly suggests an aortic dissection. The diagnosis is confirmed by CT angiography, which shows tear in the aortic intima. Immediate blood pressure control is essential to prevent further tear propagation, depending on the location and extent of the dissection surgery. You required particularly if the dissection involves the ascending aorta. Why not B? Acute myocardial infarction presents with chest pain, but it is typically not associated with the radiating pain to the back or the findings on CT angiogram. Why not C? Pulmonary embolism typically presents with sudden onset of shortness of breath and pleuritic chest pain, but it does not cause aortic dissection. Why not D? Pericarditis with sharp pleuritic chest pain that improves when sitting up, but it does not cause the sudden severe chest pain or the CT findings seen in this patient. Question 20. A 55-year-old male presents with new onset tremors, bradykinesia and rigidity. He has a history of mild depression and sleep disturbances. On examination, he has a resting tremor, cog or rigidity, and a stooped posture. What is the most likely diagnosis and what is the first-line treatment? A. Parkinson's disease, levodopa. B. Essential tremor beta blockers. C. Multiple sclerosis interferon therapy. D. Huntington's disease, tetrabenazine. Answer A. Parkinson's disease, levodopa. Explanation. The patient's resting tremor, bradykinesia, rigidity, and stooped posture are classic signs of Parkinson's disease. The first-line treatment for Parkinson's disease is levodopa, often combined with peripheral decarboxylase inhibitor e.g. carbidopa, to prevent peripheral breakdown of levodopa and enhance its efficacy in the brain. Why not B? Essential tremor is characterized by action e.g. when reaching or holding objects, not resting tremors. Beta blockers are first line for essential tremor, but the patient's symptoms are more consistent with Parkinson's disease. Why not C? Multiple sclerosis typically presents with neurological symptoms like vision changes, weakness, or numbness and is not characterized by the classical motor symptoms of Parkinson's disease. Why not D? Huntington's disease presents with involuntary, jerky movements, and the primary treatment focuses on managing the symptoms, such as with tetrabenazine for movement control. This patient's presentation is more consistent with Parkinson's disease. Question 21. A 42-year-old female presents with fatigue, weight gain, and cold intolerance over the past 6 months. She also reports constipation, dry skin, and thinning hair. On examination, she has a puffy face, hoarseness, and delayed reflexes. Laboratory results show elevated thyroid-stimulating hormone (TA) and low free. What is the most likely diagnosis and what is the first-line treatment? A. Hypothyroidism, levothyroxine. B. Hypothyroidism and methimazole. C. Addison's disease, hydrocortisone. D. Cushing's syndrome, a dexamethasone suppression test. Answer A. Hypothyroidism and levothyroxine. Explanation. The patient's symptoms, including fatigue, weight gain, cold intolerance, constipation, dry skin, and thinning hair, are classic signs of hypothyroidism. The elevated TH and low free to confirm the diagnosis. The first-line treatment for hypothyroidism is levothyroxine, a synthetic form of thyroid hormone, to normalize thyroid hormone levels. Why not be? Hypothyroidism typically presents with symptoms of increased metabolism such as weight loss, heat intolerance, and tremors, which are not present in this patient. Why not C? Addison's disease presents with fatigue, weight loss, and hyperpigmentation, but the thyroid lab results and lack of electrolyte abnormalities rule it out. Why not D? Cushing's syndrome would present with symptoms like central obesity, moon phases, and skin changes, but the findings of elevated TH and load do not fit this diagnosis. Question 22. A 55-year-old male with a history of hypertension presents with sudden onset of severe headache, nausea, and vomiting. He is found to have a blood pressure of 210 on 100 twetm Hg. Neurological examination reveals no focal deficits, but he is disoriented. Acne of the head shows no hemorrhage. What is the most likely diagnosis, and what is the immediate next step in management? A. Hypertensive emergency, intravenous antihypertensive medications. B. Subarachnoid hemorrhage, lumbar puncture. C. Acute ischemic stroke, intravenous thrombolytics. D. Migraine headache, sumatriptan. Answer A. Hypertensive emergency, intravenous antihypertensive medications. Explanation. The patient's severely elevated blood pressure and acute symptoms of headache, nausea, and vomiting are consistent with a hypertensive emergency where there is evidence of acute end organ damage, e.g. encephalopathy. The next step is to administer intravenous antihypertensive medications, e.g. nitroprusside, libitalol, to lower the blood gradually to prevent further complications. Why not B? Subarachnoid hemorrhage typically presents with the worst headache of my life and may be confirmed by showing blood in the subarachnoid space. His patient CT was negative for hemorrhage. Why not C? Acute ischemic stroke would present with focal neurological deficits such as weakness, speech difficulty, or numbness, none of which are present in this patient. Why not D? Headaches can cause nausea and vomiting, but the presence of markedly elevated blood pressure and the lack of typical migraine history suggests this is not the correct diagnosis. Question 23. A 29-year-old female presents with a complaint of intermittent joint pain, particularly in her hands and knees, along with a butterfly-shaped rash on her face. She has a history of photosensitivity and oral ulcers. Laboratory studies reveal positive anti-nuclear antibodies on an anti-double-stranded DNA antibodies. What is the most likely diagnosis and what is the initial treatment? A. Systemic lupus erythematosus. C. Hydroxychloroquine. B. Rheumatoid arthritis. Methotrexate. C. Psoriatic arthritis. Non-steroidal anti-inflammatory drugs. NSAIDs. D. Dermatomyositis. Corticosteroids. Answer A. Systemic lupus erythematosus. C. Hydroxychloroquine. Explanation. The patient's symptoms are joint pain, butterfly-shaped rash, photosensitivity, and oral ulcers combined with positive ANA and DNA antibodies are highly suggestive of systemic lupus erythematosus. SLE hydroxychloroquine is the first-line treatment for SLE as it helps control symptoms and prevent flares. Why not B? Rheumatoid arthritis presents with symmetrical joint pain and swelling, but it does not cause butterfly rash or positive DNA antibodies. Why not C? Psoriatic arthritis is associated with psoriasis and joint involvement, but does not typically present with butterfly rash or positive anti-DNA antibodies. Why not D? Dermatomyositis is characterized by skin changes, e.g. heliotrope rash and muscle weakness, which are not present in the patient. Question 24. A 40-year-old male presents with a non-productive cough, fever, night sweats, and weight loss over the past 3 weeks. He has a history of recent travel to sub-Saharan Africa. A chest X-ray shows a cavitary lesion in the upper lobe of the right lung. Sputum culture grows acid fast bacilli. What is the most likely diagnosis and what is the initial treatment? A. Tuberculosis, rifampin isoniazid, pyrazinamide, and ethambutol. B. Lung cancer, surgical resection. C. Aspergillosis of voriconazole. D. Histoplasmosis amphotericin B. Answer A. Tuberculosis of rifampin isoniazid, pyrazinamide, and ethambutol. Explanation. The patient's symptoms, travel history, and chest X-ray findings are suggestive of tuberculosis TB, a bacterial infection caused by Mycobacterium tuberculosis. The initial treatment regimen for TB includes a combination of rifampin isoniazid, pyrazinamide, and ethambutol to prevent the development of resistance. Why not B? Cancer may cause weight loss and a cavitary lesion, but it is unlikely to present with fever, night sweats, and positive sputum culture for acid-fast bacilli. Why not C, aspergillosis typically presents with a history of immunosuppression and may cause pulmonary nodules or cavities, but is not associated with acid-fast bacilli in sputum culture. Why not D, histoplasmosis is endemic in certain regions and may present with pulmonary symptoms, but it would not cause acid-fast bacilli to appear in the sputum culture. Question 25. A 63-year-old female with a history of hypertension, diabetes, and hyperlipidemia presents with sudden onset right-sided weakness and difficulty speaking. She is alert but has expressive aphasia and right hemiparesis. Aechinea of the brain shows no acute hemorrhage. What is the most likely diagnosis and what is the initial treatment? A. Acute ischemic stroke. Intravenous tissue plasminogen activator, TPA. B. Transient ischemic attack, antiplatelet therapy. C. Brain tumor. A surgical biopsy. D. Bell's palsy, corticosteroids. Answer A. Acute ischemic stroke, intravenous tissue plasminogen activator, or PA. Explanation. The patient's sudden onset right-sided weakness, expressive aphasia, and risk factors, hypertension, diabetes, hyperlipidemia, are indicative of an acute ischemic stroke. The next step in management is the administration of intravenous TPA within 4.5 hours of symptom onset to break down the clot and restore blood flow. Why not B? A transient ischemic attack TIA, present similarly but resolves within minutes to hours. The lack of resolution and the severity of symptoms point to an acute ischemic stroke. Why not C? Brain tumors can cause neurological deficits, but this patient's sudden onset and the absence of mass effect on the CT scan make tumor unlikely. Why not D? Bell's palsy causes facial weakness but does not cause hemiparesis, aphasia, or focal neurological deficits seen in this patient. Question 26. A 55-year-old male with a history of smoking and heavy alcohol use presents with a 2-month history of difficulty swallowing, weight loss, and a persistent cough. He has a hard, non-tender mass in the left neck. A barium swallow reveals a narrowing of the esophagus. A biopsy of the mass shows squamous cell carcinoma. What is the most likely diagnosis and what is the next step in management? A. Esophageal cancer, a staging with CT and endoscopic ultrasound. B. Gastric cancer, upper gastrointestinal endoscopy. C. Laryngeal cancer, either the neck. D. Oral cancer, biopsy and surgical excision. Answer A. Esophageal cancer, staging with CT and endoscopic ultrasound. Explanation. The patient's symptoms of difficulty swallowing, weight loss, and a neck mass combined with the diagnosis of squamous cell carcinoma suggest esophageal cancer. The next step in management is staging with ACAN and endoscopic ultrasound to evaluate the extent of disease and plan for potential surgery, chemotherapy, or radiation. Why not B? Gastric cancer would present with upper abdominal pain, bloating, or gastrointestinal bleeding, but not with a neck mass or dysphagia as primary symptoms. Why not C? Laryngeal cancer would present with symptoms such as hoarseness or difficulty speaking, not difficulty swallowing. Why not D? Oral cancer usually presents with a lesion in the mouth or tongue, and the patient's symptoms and biopsy findings are more consistent with esophageal cancer. Question 27. A 25-year-old male presents with a sore throat, fever, and a rash that started on his trunk and spread to his limbs. On examination, he has a strawberry tongue and a blanching erythematous rash. He reports a recent history of a sore throat and difficulty swallowing. What is the most likely diagnosis and what is the next step in management? A. Scarlet fever, antibiotics, penicillin. B. Measles, vitamin supplementation. C. Rubella supportive care. D. Hand, foot, and mouth disease. Supportive care. Answer A. Scarlet fever, antibiotics, penicillin. Explanation. The patient's symptoms of fever, sore throat, strawberry tongue, and erythematous rash, along with the history of recent sore throat, are suggestive of scarlet fever, complication of group Streptococcus gasopharyngitis. The appropriate treatment is antibiotics, typically penicillin, to eradicate the bacteria and prevent complications. Why not B? Measles presents with prodromal coryza and conjunctivitis, followed by characteristic rash starting at the head and spreading downward. Why not C? Rubella is associated with maculopapular rash and mild symptoms, but it does not present with strawberry tongue or sore throat. Why not D? Hand, foot, and mouth disease presents with sores in the mouth and rash on the hands and feet, but it does not cause strawberry tongue or history of group streptococcal infection. Question 20. A 50-year-old male with a history of alcohol use disorder, presents with confusion, ataxia, and ophthalmoplegia, is unable to walk without assistance and has a history of poor nutrition. What is the most likely diagnosis and what is the next step in management? A. Wernicke's encephalopathy, intravenous thiamine. B. Korsakoff syndrome, a long-term thiamine supplementation. C. Alcoholic cerebellar degeneration, physical therapy. D. Hypoglycemia, oral glucose administration. Answer 8. Wernicke's encephalopathy, intravenous thiamine. Explanation. The patient's confusion, ataxia, ophthalmoplegia, and history of alcohol use disorder suggest Wernicke's encephalopathy, neurologic emergency caused by thiamine deficiency. The first-line treatment is the administration of intravenous thiamine to prevent progression to Korsakoff syndrome or permanent brain damage. Why not B? Korsakoff syndrome is chronic complication. Alcohol abuse that results in memory impairment, but it does not present acutely with the symptoms seen in this patient. Why not C? Alcoholic cerebellar degeneration presents with ataxia, but it does not cause the acute confusion or ophthalmoplegia seen here. Why not D? Hypoglycemia may cause confusion and ataxia, but the specific symptoms of ophthalmoplegia and the patient's alcohol history point to Wernicke's encephalopathy. Question 29. A 68-year-old female with a history of diabetes and hypertension presents with sudden onset severe chest pain radiating to her back. Her blood pressure is 210 on 100 mHg and she is diaphoretic. A angiogram reveals a tear in the aortic intima. What is the most likely diagnosis and what is the next step in management? A. Aortic dissection, blood pressure control and surgery. B. Acute myocardial infarction, aspirin and thrombolytics. C. Pulmonary embolism, anticoagulation therapy. D. Pericarditis, non-steroidal or anti-inflammatory drugs, NSAIDs. Answer A. Aortic dissection of blood pressure control and surgery. Explanation. The patient's sudden onset severe chest pain radiating to the back along with the history of hypertension strongly suggests an aortic dissection. The diagnosis is confirmed by CT angiography, which shows a tear in the aortic intima. Immediate blood pressure control is essential to prevent further tear propagation. Depending on the location and extent of the dissection, may be required, particularly if the dissection involves the ascending aorta. Why not B? Acute myocardial infarction presents with chest pain, but it is typically not associated with the radiating pain to the back or the findings on CT angiogram. Why not C? Pulmonary embolism typically presents with sudden onset of shortness of breath and pleuritic chest pain, but it does not cause aortic dissection. Why not D? Pericard presents with sharp pleuritic chest pain that improves when sitting up, but it does not cause the sudden severe chest pain or the CT findings seen in this patient. Question 30. A 35-year-old male presents with a rash on his cheeks and neck along with fever, fatigue, and muscle aches for the past 4 days. He has a history of a recent upper respiratory infection. On examination, he has a maculopapular rash that started on his face and has spread to his trunk and limbs. His lymph nodes are mildly enlarged and he has a positive Brudzinski sign. What is the most likely diagnosis and what is the next step in management? A. Meningitis due to mumps virus. The supportive care. B. Rubella vaccination and isolation. C. Measles vitamin or supplementation. D. Parvovirus. B. Infection and supportive care. Answer A. Meningitis due to mumps virus or supportive care. Explanation. The patient's rash, fever, and muscle aches, along with the history of recent upper respiratory infection, are highly suggestive of mumps viral infection that can cause viral meningitis. The maculopapular rash starting on the face and the positive Brudzinski sign suggest possible meningitis. Supportive care is the primary treatment for viral meningitis caused by mumps. Not B. Rubella presents with maculopapular rash, but it does not cause meningitis or the positive Brudzinski sign, which indicates meningitis. Why not C? Measles would present with characteristic prodrome of cough, coryza, and conjunctivitis followed by maculopapular rash that starts on the face and spreads downward. Why not D? Parvovirus B causes erythema infectiosum, fifth disease, which presents with slapped cheek rash, does not cause meningitis or the other symptoms described.